we'll start back up. This next slide is a slide that basically came out of Jason Mushik's work that he just put out in this journal. Jen, what's the name of the journal? Sports X. European journal? UK. All three of his articles are up here. We'll put them on, Jen, we'll put them on that table for you guys to look at. I just think these rock. He did such a great job. He talked about the femoral acetabular impingement mechanisms, diagnosis, and treatment options using postural restoration, part 1. Femoral acetabular impingement mechanisms, diagnosis, and treatment options using this, part 2. And then he went into this part 3 on treatment options and using the diagnosis as a baseline for treatment options. What I like about it, you know, a few years ago, femoral acetabular, FAI, started showing up in the literature, Joe. We started seeing articles on FAI, femoral acetabular impingement. He does a good job of that. But he blends in this AF stuff. You know, I mean, we were finally getting into things that move on each other. And then they put an IR and ER. Katie, even when you were in school, I don't know if you got any FAIR or FAI. I mean, it's kind of cool. So take a look at this. Jen will put it on that table. But this came directly out of that published work of Jason. And it's kind of exactly a reflection of what we did right before the break. If you put your weight on your right side and right stance, and you move your acetabulum over that femur, that's called right AFIR, / that means simultaneously on the left side you have left AF, Bobby, thank you, ER. And if you could walk in a direction where you're going now clockwise, you would remain in that orientated and positional pattern. But we got to walk straight. So to walk straight, we have to compensate. And the extremity we're going to have to compensate with is the left side more than the right, because we're already in pronation on the right side. We're already there. You take your left foot out, if the left foot isn't externally now what? Rotated, we wouldn't be able to walk a straight line. And now we've got some problems with impingement and issues going on the front of this hip and some issues going on the back of this hip, including what's going on at the pelvis floor, which is another course, including what's going on at the pelvis and the SI joints, which is in this course, towards the back of your manual. That FAER compensatory activity, kind of what we were just looking at the break with that young lady, she can't shift enough, is then transferred into joints that were not made for transverse activity. Thank God our knee was not made to be a hip, and our SI joint was not made to be frontal plane. It's wedged, a frontal plane mover. So when they start to be taxed, i.e. your SI joints, your pube, and your knee for triplanar movement that should be occurring at the hip, you get these impingement syndromes, all because of the compensatory activity. We're really good as humans taking legs and turning our legs and arms out to compensate to walk straight lines. We're really good at doing that. Well, because we can do it. We have the ability to do it. And then on the other side of the handout, you see on the other side of the screen, you see right AFER followed by left AFIR. Now, if you would, just take your pencils or your pens and circle that right side and then just write down, this would be a treatment goal 70% of the time of patients you work with. Gibby, what do you think? Is it greater than 70%? Possibly.
Yeah.
That is treatment goal. That is a goal, Chad. I mean, what do you think in your life? 80% of those patients need that?
At least.
No, I mean, you got to just put it up there high. We have no research on the percentile, but just put down a high number. That is one of the things you should always, Sheila, in the work you do, you just want to watch patients to see if they can get their right leg to come forward without their left hip staying forward. I had a patient last week. All I did, you were in the room, Carl. You were in the room. Carl, what did I do in the room? Now, don't say hamstrings now. But what did I do? We just gave her 2 or 3 things to work on. What was that? What was it?
Left AFIR
With
right foot forward And then left AFIR with right foot behind.
With right foot back. But more importantly, what did we really stress to the patient? We said to the patient,
Keep your left hip back.
Behind the
Right.
Hey, you know what? You can eat your eggs in the morning, drink your toast. I hope not. Drink your orange juice, eat your toast. But you always want to make sure that the left hip is behind the
Right.
and the right hip's always in front of the
Left.
whenever possible. And that was all we did, and that's all she really wanted. Did you notice that? Coupled by which shoulder did I want to keep behind what shoulder?
Right shoulder behind left.
When her right hip is in front of the
Left.
Let's do that, everybody. Keeping the right hip in front of the left. Stand up, everybody. Let's do it. Let's just do it right now. Are you ready for this? Carl's going to tell you what to do. Carl, what did we tell that patient to do?
Left hip behind right hip.
Can you pick this up, Don? It's okay. Right hip behind what?
Left hip behind right hip.
Oh, thank you. Left hip behind right hip. Okay.
Right shoulder behind left
Everybody, first of all, how do you know your left hip is behind your right hip? Maybe touch it. Maybe move your left hip back. Maybe look down at it. Don't assume you know it. Do you follow me? Just make sure you know you're kind of doing it. Get it back there a little bit. Work at it, Carl. Unlock the left knee. Unlock it. Feel it. Don't work so fast at this. You know, I won't use her name. Doesn't get that. Do you follow me? So just feel it. Just sense it. Get it. Hold it. This patient's life is going to change, Carl, if that's all she does for 3 or 4 weeks, right? Bleed it. Now what are we going to do?
Now you're going to bring your right shoulder behind left shoulder.
Okay.
Left hand forward, right hand back.
Without moving your left hip, Carl, forward. Now, how do you know the right shoulder is behind the left shoulder? Look at it, sense it, twist, twist, and twist. Move your left hip back some more, everybody. Oh, you should have felt more twist. You didn't have to twist your shoulder back. You got more twist when Carl said move your hip back, right? That is the goal. That would be the goal. Everybody feel that? Now pick up your right foot a little bit and see if you can stay there in balance without falling. Okay, move your left hip back some more. Now squat a little bit. Good. Add a little more. Cinch that baby up. Got it? Now relax. Let's see if it's easier on the other side, Drew. Carl, you ready? Tell us what to do on the other side.
Right hip behind left hip.
Okay, got
Make
that
sure-
right? Check.
Make sure it's there. Look
Yep.
down, feel it. Now, left shoulder behind right shoulder. Right hand forward, left hand back.
Okay, push your right hip a little further back, bend the right knee. Whenever you feel ready, pick up your left foot. Did that feel easy for you to do? That is our number one goal in this course, to get the innominate to move back on the left side. Have a seat. Now your innominate's going to move better back on that left side with what muscle?
Hamstrings.
And with whole control of the obturator. Okay? So when you hear me say the word obturator foramen, think adductors and obturator. But think adductors. We're going to color all these. When he says shift your left hip back, the only way you could shift your left hip back was through knee flexion, because the knee is flexed by the muscle that's moving your pelvis back. What's that muscle called, Carl?
Hamstring.
4 out of 4. That's why we said bend the knee, because if you can't bend the knee, you cannot get more posterior translatory movement out of that hip, because the hamstring is going to be the one that moves you which way? Back. It's a posterior rotator. It shoves your knee forward, which means the hip's going to go back. So that's why these articles that Jason wrote are so cool, because he goes over all that. And Mike, in your world, that's called squatting. It's called lifting. It's called power. Here's an illustration that kind of shows you the magic number. We all need about 30 degrees of power. We call that 30 degrees neutrality. Your Homogeneous, you're just more relaxed at 30 degrees of neutrality. 30 degrees of lumbar lordosis is neutrality. 30 degrees of cervical lordosis, as some of you, Katie, heard me last week talk about, is neutrality. If I'm working with a neck patient, I got to make sure I have AFIR, Katie, on both sides. 30 degrees of cervical or lumbar lordosis is neutrality. If you go into more than 30 degrees, you have to start to compensate. More than 30 degrees means femurs are oriented inwardly. And now you have to start to diverge, pull things out, externally rotate. The lat kicks in. The psoases are external rotators. Your glute max becomes dormant. It has no positional power left. Your sagittal muscles become transverse rotators for externalism. Lat, psoases, quads, hamstrings, all become now muscles for external rotation. Your frontal plane control goes down. You lose it. Your ability to shift is lost when that 30 degrees goes higher. When you go under 30 degrees, you lose your butt. You're leaning back. You have no need for glutes. You're laying on ligament. You're laying on anterior chain tension. You're laying on it. It's holding you up. You are not expanding when you breathe. You can't open up. You breathe by going forward and back. Forward and back. And I could talk forever about those 30 degrees, but the main thing is, do we want to preserve that 30 degrees? Yes, because you want a little bit more on each side. Every step of the cycle is going to have this side go up while this side goes down, or this side go up while this side goes down. This is the transition state. This is from here to there, right there. I'm in a transition state where my pelvis is no longer staying behind me. It's starting to come what? Forward. And I'm now starting to then to shift over to my left side, leaving neutrality, and now getting an AFER on the right, AFIR on the left, for more than 30 degrees. Less than 30 degrees on the other side. I'm going to pick up. Lydia, I transition. There's my 30 degrees. Do I want 0 at transition? No. Do I want 40 degrees at transition? No. I want what? Mama bear transition. If I have 40 degrees on one leg, 30 neutral, nothing on the other side, I'm still a papa bear on one side, not even been born on the other side. Do you follow me? I'm staying there. And that transition state now is my other side, instead of the other side being the other side. Really important for you to understand, this is just not a simple chart. This is what we call transitional movement, so you don't have to work so hard, so your body is protecting itself. Sheila, our bodies protect ourselves when we have unilateral activity occurring correctly after the unilateral just occurred correctly on the other side, which makes you what? Bilateral minded. If you don't have that, then you are unilaterally minded, and now you have to protect yourself. And tension has to go what? Up. In this course, the tension that's going to go up is this need for you to overextend a knee with a quad. Overextend a back. Just say the word overextension is protecting yourself. So why are you really here? Why are we here? We are here to not overprotect you, but to, can you write this weird way of thinking? Underprotect you. We are here to get you to do less. Because if you're doing less, the weight of the body is going to keep you underprotected. When you need more overprotection because of what you're doing, it will be there now. Versus going into need for overprotection when you're already in a state of over what? Protection. Overprotection means rest in peace, a rip. You know what a rip is? A tear, tendonitis. Rest in peace means now you're mortality-wised up. You can't move. We'll take you out of the game for 6 weeks. Rest in peace. So you can come back and rip it again. That's overextension on overextension. Overprotection on overprotection, Brian, doesn't add up, with a championship volleyball team. You can't do that week after week after week after week. So it's important for you to remember this page 8's don't take lightly. The question would be, are your client capable of preserving 30 degrees of neutrality? This is a right rotation on a right oblique axis if you're a sacral person. And I put it in here because that means the spine is going to be oriented to the right side. If I'm going to do something, Chad, to pick something up to my right side, I'm going to go into right AFIR. I hope to goodness all of you do. And if I'm going to pick something, Lydia, up on my left side, I hope you're going to leave right AFIR and go into what? Left rotation on a left oblique axis. That's not rotation. That was just orientation. So then I can pick it up and have all the freedom in the world to work my spine, Chad. Anything I do with the weight or anything I do. But if I'm already over-rotating my spine, I don't have any rotation left for you, Chad. I don't know where to get that rotation rotation that left. Back. So it reminds me to remind you that when you look at the axis of the sacrum, that axis is following the innominate. This is a very gross picture to me. Gibby cringe even having it in the manual. Would anybody like to tell me what grosses me out in this picture? Someone actually had the guts to disarticulate a sacrum from the innominate and put it in front of my face. You understand that, Bobby? Somebody had the audacity to put a sacrum with a spine on it without any innominates. I don't know about you guys, but this makes me want to throw up. You don't probably see that. But I don't see humans walking around without innominates. Oh, I guess I do. I guess it's okay. Because the only way that sacrum is going to go on that oblique axis is through the what? Do you think that sacrum has a little brain saying, I'm going to move myself? Do you think your sternum has a little brain that says, I'm going to move myself? Do you think the sphenoid has a brain that says, I'm going to move myself? The answer would be no. It has pairs of bones that move it. And those pairs of bones are regulated by that sacrum. That sacrum is dead because it has nothing to regulate. And you're getting a picture that's saying, that's an illusion. That's a picture saying, if you move your sacrum to this position, the spine's going to follow. Folks, it don't work that way. That's why I challenge you. When you look at that picture and you see that rotation, that's not a true representation of what's going on because, Gibby, what's missing? The only way that could happen would be with a pair of innominate bones. Someone took it off because someone likes to play with what? Just say it. Sacrums. As if they lived in a vacuum. You can't get right on right and left on right if you don't have a nominant what, Brian? Control doing it. It can't happen. Now, I'm going to get into this real quickly this afternoon, but right now, briefly, there are 3 muscles that control that innominate on that sacrum. Write it down on this picture. I wonder what happened to these 3 muscles. The piriformis, the glute max, and Mr. Obturator. I wonder what happened to those 3 muscles. Because those are the 3 muscles that made that happen. And if you don't take those 3 muscles and put them back on, and you think only that way, wrong course. which is why I'm struggling to keep it in the manual, if you want to know the truth, Jen. Does that make sense to everybody? There's a better picture. Whew, I was getting a little worried. There's a better picture of the same thing you just looked at being driven by tri-axis activity through what bones? The nominants. And I won't take, but you've got sagittal, horizontal, and frontal axes now. Because we put back on that sacrum a what? A set of nominants. That's a better picture. I can breathe a little better. And you guys, I'm just trying to teach. You can't look at the sacroiliac joint, and this is the sacroiliac joint. Please write this down, Sheila. L5S1. Write it down. That's a sacroiliac joint. I didn't say that incorrectly. L5S1 issues are sacroiliac patients. Sacroiliac patients are L5S1 patients. You can't look at this, Katie, differently after a course like this. Because the only thing that's sandwiching that three axes are nominants that keep you what? Together. Loosely jointed together. Can't look at it any other way. Page 9. We're going to go over this fairly quick because as I looked at it last night, I don't really think, Jen, over the years, this has changed a whole lot. And I'm proud of that, Ben. So if you look at it, it's written in a way that I think you'll find easy to reference from this point on. I broke it up into sections. You have anterior capsular ligaments, and you have posterior ones. Let's start with the capsular ligament structures on the front. The big one is the iliolumbar ligament. It goes right into your low back musculature, and the sacrospinous ligament. And I'm going to go to my friend Carl. That sacrospinous ligament is your what?
Hamstring.
And that's all you got to remember. Just remember that. Just write hamstring under that sacrospinous ligament. There's research will tell you that there's some ethic groups out there that have more hamstring tendinous insertion to this ligament than others. There's lots of studies on the sacrospinous ligament, but it goes from the lateral aspect of your sacrum and the coccyx to the spine and the ischium. And we'll show you a picture of it, but it's really basically synonymous with the tendon of the hamstring. There it is. There's your sacrospinous ligament. I'm going to also remind you that the obturator muscle, the internal obturator muscle, goes right around that in a 90-degree turn. It's coming up later, but that sacrospinous ligament, if that spinous ligament goes up or goes down, the tension on that ligament gives you more or less whole control of your obturator foramen. So if the sacrospinous ligament goes up or down, you are really regulating tension in the system with that ligament. Okay? Now, remember, this sacros tuberous ligament, we're coming up as your hamstring, but this is also considered a hamstring-like muscle. Because if you pull this down, this shortens up. And like I said, there's literature will tell you that the hamstring actually is part of that ligament. And we'll show you that in a minute. But really, this ligament on the posterior side, which we haven't gotten to, is really more hamstring than this ligament. But these two ligaments are responding to what?
Hamstrings.
Activity all the time. Hamstrings, therefore, set the tone of the pelvis. Hamstrings also set the pressure of the pelvis. If the pelvis is regulated by hamstring function, your awareness of yourself goes up or goes down because you're basing that hamstring function off that floor at heel strike. So this anterior ligament, you have two of them. Do you see how this blends in with your iliolumbar soft tissue? This is called the iliolumbar ligament. And then you got this quadratus, I call it the iliolumbar muscle, which is the quadratus lumborum that goes right here. L5 is connected to the innominate with the iliolumbar ligament. So when your innominate moves, your fifth vertebrae knows it. Then you got these posterior ligaments. And the sacros tuberous ligament, I'm going to do it again, is considered what, Carl? A hamstring. So your sacrospinous ligament and your sacros tuberous ligaments, I consider hamstring ligaments. Okay? The one controls the orientation of the sacrum. That would be this one. And the other one controls the orientation of the innominate because of its attachment, and that's this one. But this is directly coming up from the hamstring tendon. This ligament and this ligament are hamstring ligaments. All right, that's a pretty good, doggone good picture of that. And then we got your sacros tuberous and sacrospinous ligaments, hamstring ligaments from the side. This orientation is preserved. This 30 degrees is preserved by these ligaments. Can you just write this down? Sacroligaments. Write down sacroligaments. Directly influence lordosis of your lumbar spine. I always chuckle, Drew, when people tell me that they're going to put people on an abdominal program to reduce lordosis. I have no problem with that thinking. I have a real problem with that thinking if you forget to look at the position that you're in at the time you do your abdominal program. Because if you don't have hamstring co-activation with those abdominals, you can be working abdominals and you can be training abdominals to be sacral ligaments. Abdominals do not have direct contact with the floor. You'll make somebody really strong in a wheelchair. Oh, I'm sorry, those wheelchairs. The ones that handicap you when you work on a computer every day. You'll make yourself really strong in a chair. Let's take the wheels off. You know, I did a lot of work in my early days in the VA. We worked abdominals because we didn't have the opportunity to strengthen hamstrings. These quads and these paras didn't have their hamstrings. So we did everything we could with their abdominals because they were in a chair. Your athletes that you work with usually are not in chairs. A lot of them are, but a lot of them are not in chairs. I would encourage you to think about abdominals as being sacral ligaments. Therefore, a myokinematic course to strengthen the outcome of an abdominal program would make sense if you co-activated the muscle myokinematically with the ligament that you're trying to keep in the right position for correct operation of trunk flexion with hip concomitant extension. I see abdominals right there. I also see abdominals because I see an obturator membrane. You know what an obturator membrane does? It allows you to get in a plane and not have to explode. It's a pressure regulator. Do you see the obturator foramen? That has to move in and out. That hole's there for a reason. It's absorption. It's the best Monroe shock absorber you can buy at an auto store. You know what shock absorbers do, right? I see a shock absorber in the foramen, and I see abdominals in the back. I'm kind of a weird guy. That's what I see. So does this illustrator. So this is a good picture of when this pelvis goes forward, this has to give more shock. When this goes back, this is going to be more tense. So things are going to move a little bit easier when you're in a non-lordotic state. Things are not going to move so easy when you're in a lordotic state. Pressure's got to go out. You better hope to God you got a frontal plane when you're in a lordotic state. Okay? The first is called an inlet, and the second is called an outlet. And these inlets and outlets are constantly in tension with each other. They're constantly, on this slide, if you have it, somewhere in your manual, if you could just write this, inlets and outlets vibrate. Obturator foramen, vibrate. There's vibration here. There's vibration here. And there's vibration here. Does that make sense? Expansion, compression. Expansion, compression. Expansion, compression. Expansion, compression. Expansion, compression. Expansion, compression. They vibrate. You have an inlet and an outlet. You have a left one, a right one, a front one, and a back one. Whole nother course. Okay? And you have these two obturators. The pelvis discussion in this course are the obturator foramens. These beautiful foramens that were given to you for a reason. They were given for you to move, to control your ability to move without using that joint to control it. This joint controls that movement. There is very little muscle connected to that capsule. There is huge amounts of muscle connected to that capsule. Whales have these bones. Any mammal has this bone. Any mammal that's going to be needing a diaphragmatic mode is going to have this bone. That's called control. This is control. Patients that you work with have control only on one side. We're evening out the planes, inlets and outlets with transition. Muscles that stay in a plane of oblique patterning can't transition. That's another course called pelvis. Are there any questions about what I just talked about? Because we're going to get into this frontal plane tomorrow, big time. Carl, did that help? Don't say hamstring. That help? All right, page 9, everybody. These are the muscles that I think of when I think of pelvis. That would be your piriformis, your coccygeus, your iliococcygeus, and gluteus maximus. And I know in your manual you have this in a number of places, so I'm going to kind of roll through this pretty fast, okay? This is the picture from the inside down. This is your inlet view of a female. And you can see the piriformis muscle, the coccygeus muscle, and you can see the pubococcygeus muscle in the front. All these muscles myokinematically need to be in that position and need to shock absorb. This muscle and this muscle help your obturator. This is part of the glute complex. This coccygeus muscle is part of your glute max complex, as is these muscles. Those small muscles, the obturator internus, externus, piriformis, we're going to color those. It's really about the same thing. There's not that much difference between pelvis of male and female. Females have wider pelvises. They have more things they've got to work on with pelvic control than a male does. Male's lazy in this area. This is a great picture. I love this slide. And Jen, I like it for so many reasons. I was thinking about it. We need to get our illustrator draw this one, okay? This is called the glute max, and that's called the coccyx, and that's a raphe all the way to the pube. That's a important thing to remember, that there's a quadrant here. And this baby right here, this is what controls your sacral plexus. This is the inferior fiber of the glute max. It's the most powerful external rotator you have. Therefore, it's the most powerful shock absorber as a rotator you have. It's the most powerful shock absorber as a rotator you have. As a rotator. It keeps your upper flares alive. In other words, when the lower pelvis is pulled together with this glute max fiber, watch what happens to my inlets. They open. When the glute max gets weak and you roll forward, they close. And in other courses, we're going to talk about how one stays closed and one stays open. But this glute max is made for powerful elongation eccentrically. Every time you land, it eccentrically gives. It concentrically gives you push. Look at the push. Push. You're pushing the toothpaste out of a toothpaste bottle. You're pushing it. You're lifting it. You're providing a fulcrum for your diaphragm. It's a pusher. So the glute max fiber you definitely want in the right position. And you keep it in the right position by muscles that are frontal plane minded, so it can become the boardwalk, the park place of Monopoly. It's supposed to be a rotator. It was never supposed to be a sagittal puller. The sagittal puller is your hamstring. I won't write it down, but can you write it down? Maybe I will write it down. The first muscle we should be thinking about is sagittal hamstring. Sagittal hamstring. Then you go to frontal. And you go to the frontal, you got to think of adductors. And you could put the word abductors up here as well, but abductors, adductors. This is just to get you repositioned. But now we're on this muscle called the glute max. Transverse activity begins with the glutes. And the one that starts it is Mr. Maximum. Your minimus and your medius won't have a direction if Mr. Maximus isn't there in the right position. The maximus sets the tone for the medius and the minimus. Because if the maximus can adduct an innominate, that means it can influence the adductors and the abductors that are attached to the innominate. If I have my maximus not working, my adductors may not work, and my abductors may overwork, or vice versa, depending on the position you're in. So the glute max muscle is the first big critical rotator you've got. You win the game with the glute max. It gets you shifted. It moves you. Your volleyball player has beautiful glute maxes as sagittal muscle. She's sagittally working those glute maxes, or sagittally making her play well. But her frontal plane muscle and her transverse plane muscle is taken up by other muscles because she can't get out of sagittalism. And we hope she's not going to get hurt. So that glute max is that first muscle that you really want to think about when it comes to winning the game. Glute max. Shifter. It's a shifter. It's the best adductor you got, Gibby. Because if I kick it on my right side, I immediately have to transfer my weight over to the left. And maybe I don't want to kick over to the left. Maybe I want it on. It's pushing me to the left, but maybe I want to be stable over here. There's nothing wrong with that. So it's such a cool muscle for so many reasons, and that's why I love this picture. That low fiber, look how low. Everybody sees glutes and they think, man, those look like good glutes. No, where is a good glute? Way under here. That's the good glute. That baby, way under there, is your good glute. If that baby is way up here and you like that big glute, and your last name's Kardashian, and you like that big glute way up here, and with that deep back, I wouldn't want her on my volleyball team. Because she will be the volleyball. You understand that? You got to keep that muscle way tucked in. And that's why I like this picture here. The ligaments that we also have in the front are called pubic ligaments, and they have the three here. They're listed. They all have fibers that attach to abdominal obliques and across the front to keep you secure and tight. On this page, I asked Jen to put this in the slideshow, and I really love this. I chewed on this last night, Jen, as you know. Let's go through it. The iliolumbar ligament is a quadratus lumborum muscle. The quadratus lumborum muscle is your iliolumbar ligament. We call this a ligamentous muscle slide. Your lower glute is your sacral spinous and sacrotuberous, along with the hamstring. If you want to write the word hamstring, do you see where it says hamstring posterior sacroiliac? But if you want to put the arrow up to the sacrospinous, I'd be fine with that. Your sacros tuberous ligament, there it is, hamstring, bicep femoris. Sacrospinous, posterior sacroiliac, and sacros tuberous ligaments are therefore agonistic with hamstrings. So hamstrings are kind of an important muscle for those ligaments. And then you got your pubic ligaments, which I consider abdominals. On page 12, I isolated three capsular ligaments as they relate to capsular activity for joint dynamics. First one being the iliofemoral ligament. When your pelvis moves anterior, your iliofemoral ligament is going to move the femur inwardly. And you have all this written down, but just remind yourself that when you move that pelvis forward, that pelvis coming forward will be pulled in by the iliofemoral ligament. Your pubifemoral ligament, when you move your pelvis forward, will also pull the femur inwardly. How about this? If I want to move my innominate forward for more lordosis, couldn't I use these ligaments to help me get my pelvis forward by planting myself on the ground and pronating? If I pronate, bend my knee, I'm going to use those ligaments to anteriorly rotate my pelvis. There's a lot of weightlifter people in the room. I might need to do that. I might need to pronate a little bit so that I'm not turned out. Turning those out would pull my pelvis as well too, because it's an internal rotator. So if I externally rotate my legs, I'm also going to pull myself forward. What would be healthier? To do this, pronate, don't let my knees come in, pronate, don't let my knees come in, or supinate and pull my pelvis forward when I lift. Chad, which one would you like to do? Does this look better than that? And that's why you really want to take advantage of these pubic and iliofemoral ligaments for support. They are there to support the innominate. Everybody thinks that they're to help you move the femur, but they're there to support the innominate, especially if you're going to be using that FLOOR, which I hope you are. Then on the back, you got this ischiofemoral ligament. If you take your pelvis and you move your pelvis out, okay, it's going to externally rotate your leg, orient your leg. I didn't mean rotate. We also have got to remember that the hip has a certain attitude when you move it into 90 degrees or out of 90 degrees. And that discussion is on page 14, and it goes over some key components, and I'm going to go over them briefly. Most of your ligament structures are loose at 90 degrees. That's why 90 degrees of flexion is so cool, because you have more freedom to do things. You can sit there as a human comfortably. You can crawl as a baby comfortably. Your hip, you learn hip dynamics when you crawl in 90 degrees, because you're the most loose. Your hands are free. Your neck is free. You're free in that chair this morning. You're much more free in that chair. External rotation is accompanied by the superior glide of the femoral head. We just went over this. Rotation limited by the superior capsule iliofemoral ligament is limited by that. Internal rotation is accompanied by an inferior glide of the femoral head. And it's limited by the inferior capsule of the superior ischiofemoral ligament. When you stand, the tension in your hip goes up. Can you write that down? Standing reduces freedom. That's by design. So if you measure femoral rotation with a person in supine, it's going to be different than femoral rotation measured in sitting. That's by design. If you stand and you're looser, we know you're patho. We know that isn't good. And if you sit, you're tighter. We know you have too much what? Lordosis. Both of those tell me that there's a muscle that's not operatively working in its right position. I'll bet Carl can tell you what muscle that would be.
Hamstrings.
Because if that hamstring is not operating in the right position, what I just went over, along with the sacrospinous and tuberous ligaments, you are now in a position that you're going to need to compensate with to get triplanar activity. And now you're down the rabbit hole. Are there any questions? But by design, you were meant to be looser when you sit. And by design, Mike, you need to be a little bit more turgid up when you stand, provided you have Carl's hamstrings. If you stand and you're loosey-goosey standing, you barely hold on, and you just have nothing, we know that it is not a problem with the hip until it's a problem with the hip. The only time it would be a problem with the hip is if you have what muscle in the right, what?
Hamstrings.
Position. Because if it's in the right position and you can adduct your leg, you can give me 80 to 90 degrees of straight leg raise, you can extend 20 degrees, you have 40 degrees of internal rotation seated, 60 of external when you seat, and you still have problems with the hip, then we know you got to what, everybody? Where's my ortho doc? Please help me. There's something going on here. And even if it was a labral tear at that point, I would probably do everything I could to center, there's that word, to get centered activity upright dynamically going through neutrality. Because it's not the position you should be worried about. It's the dynamic flow that you should be worried about. When they stand and have AFIR, that's awesome, she got that. But I wonder if she can do that with every step she takes called alternating cycles of gait. Because if she can't go there out of it and come there into it, Pat, that's a bigger problem than getting it. That's called dynamic function. Mike, when we met for the lab down there, okay, I said the number one thing that I think you got to look at is what, Mike? Gait 101. Can your athletes walk? Seriously, can they walk without this overactivity going on to secure themselves in single leg stance centering? Because if they can't do that, Mike, it's not the position we can't get, they can't transition. So that's why I like page 14 when it comes to that range of motion, sitting versus standing. I live by Kapanji's range of motion. Kapanji in 1970 was the only one that convinced me he knew what he was talking about. So his research, to this day, I'm still challenged by research, because he used the word left and right. He knows there's certain things that happens in the body when you go over to the left side versus the right side. He didn't know what, but he kind of knew there's a certain thing. He could tighten things up, but he goes, this is normal flexion. This is normal extension. This is normal abduction. This is normal adduction. As soon as I say that, you can take a population of 20 and get something completely different. He also knows that. But it's called endomorphism, ectomorphism, and mesomorphism. Okay? And if we're just to look at general figures, I don't get too caught up on these range of motion values. Here's what I get caught up on. Are they changing? Did they change? Did they change with the position? You can make those numbers go up and go down neurologically too, with tone, autonomics. So it's a very, very important thing for you today to know that the reason I'm including them is for these two reasons. Circle the word extension, 20 degrees. If you don't have 20 degrees of extension, every single value on that chart is going to change. Now, Pat, that won't be in a graph. You won't see all those values reflect extension. You won't see that in a chart, Mike. But why is the chart in your manual? Is it a recap of what's out there in the manuals? Yes. But you're going to make a note. I know the speaker said, evidence-based speaker said, that if you change that extension, everything else on that chart, Carl's got to what? Change. That's what the speaker said. And you got to prove me if I'm wrong. You're going to show me the research that says that's not true. Because I'm going to show you the research that says it's true. So if you tell me you've got 40 degrees of internal rotation, and I put you into a position where you have less than 20 degrees of extension, zero extension, I know your 40 degrees became 60. And your external rotation became what? 40. Because the orientation of that innominate with that femur requires that, unless you match up the femur with the acetabulum on the table that you put the patient on. I'd have to play games with you now. But I don't want to play any games. I want to follow the school's thoughts. If that's normal, extension can change those normal scores really quickly. Now you have false representation of range of motion values. Therefore, Brian, isn't it important to pull the goniometer out of drawer and use the goniometer once you know the pelvis is in what state? Neutral. Because if you don't have a neutral pelvis, you don't know if the scores that you're testing are correctly or incorrectly representative of what you've got in front of that hip. So you have to be able to have 30 degrees of normal lordosis, 20 degrees of extension before you should pull out the goniometer and use it as actual representation of where you're at with that capsule. But you can definitely pull out the goniometer before and after a technique. And so, Jen, in our manual, we have this little box coming up that's going to say, take pre-treatment, pre-positioning measurements, Jen, and post-treatment and post-repositioning measurements. Because that's going to be a bigger indicator of what you've got than just taking measurements every time the patient comes in. So what does neutrality mean? That should be your question. What does it mean when it comes to adduction and abduction, which we'll go through the next 2 days? This is 100 degrees of flexion. This is 20 degrees of extension. And I have my hand on Bobby's superior pubic area. I want to make sure her abdomen is not relaxing. I have her supported. I have my hand on the superior ischium, ilium, superior innominate, because I want to make sure when she picks up that leg, that rear is not moving into my hand. If that rear is moving into my hand, that's not extension of A on F, which is the same thing as the extension of F on A. When she picks that leg up, that bone should not be going toward me. That bone should be going away from me. Did I lose you? Everybody understand that? If she picks that leg up and that bone is going to my hand, that is not hip extension, that's back extension. Mike, we as clinicians do not do that enough. We're worried about whether or not you've got a Thomas test that's positive or negative, whether you have a hip flexor that's overly tight or overly stretched out. We're worried about whether or not you have the ability to maybe do a sit-up. I mean, the things that we look at that look at hip flexion, if we could put the same amount of effort on our mind for hip extension as we do with hip flexion, this would be a different world. Do you have 10, 15, 20 degrees of hip extension? That would be a yes or no, Gibby. And the only way you can get that 20 degrees of hip extension is if you're using what muscle?
Hamstring.
Correctly. Because if the hamstring is no longer being used correctly because of improper position, you're going to use more back extension to get that 20 degrees than you are actual hip extension. And I do slow down. Jen, I do slow down. This is a huge concept. Everybody look into the back of the wall and look what's on that wall over there. Here's what I see. I see a sensory system that loves to extend a right femur. Do you guys see the right femur? I see a huge hamstring on the right side. A huge amount of neurological input of that right femur. Do you see the size of that right femur? I see a teeny little left femur. Now I want you to remember, what you're looking at that wall is what your patients sense. They sense huge amount of right extension on which side, everybody? I see a right femur. And when they go to the left side to get that extension, they barely even know they got a femur. That's a neurological representation of the 20 degrees of extension that you lack on the left side when an anterior nominate on that left side makes that femur feel that small and empowers the femur channel on which side. I can finally teach a course in this new building and use that wall for an explanation. You guys understand? That's what your patient's feeling. A large amount of extension to give you on which side. I have my right bone. I feel my right bone. I know where my right bone is out. I have the ability to extend my right side. I feel it. I sense it. It's huge. But on the left side, I'm going with the flow. I'm just kind of going with the flow. I don't have my 20 degrees of extension on my left side. I may have a negative 20 degrees of extension on my left side. So Katie, the real issue is not what they have for a goniometric measurement. The real issue is their behavior is patterned off of lack of sensory input coming from a side that is minuscule because they lost the ability to extend their hip. You saw that young lady walk down the hallway with a beautiful set of extensors going on what? Was it her hip that was extending? What was it that was extending on her? A beautiful big back on which side? She sacrificed all her abdominals on the left side. It was a gorgeous looking extended back on her left side. Because she's walking with a little teeny femur on the left side for neurological input, Katie. It's not even there. But boy, do I like my right side. Do you feel that right side? Man, I love my right side. I can't wait to get to that right floor again, Chad. And I'm making a big deal in this course because it's the only time in this PRI program we can actually talk about it. Because it's mild kinematics of the extension. I can't roll off this slide very well, Matt, without talking about 20 degrees of extension and the reason for that bone being so big on that wall. See, all of our programs want to make the bone on the left side as big as the bone is on the right side and make the bone on the right side look a little smaller than it really is neurologically. And the only way that's going to happen is you got to get 20 degrees of extension on that left side as much as you have on the right side. And the only way that's going to happen is you got to get that hamstring to pull that pelvis back into posterior rotation at the same time. That's the only way you're neurologically going to get that. So ma'am, could you do me a favor? Could you stand every day and make sure your left hip is behind what hip, Carl?
Right.
Good thing you didn't say hamstring. And that's the truth of the whole matter. Now, Pat, that took us to repositioning. What are we going to do with other activities in the frontal plane besides getting in and out of a car or off a toilet seat with your left leg? You've got to develop muscle on that left side. What's the first muscle on that chart that says we got to go to next? What's your program going to be oozing with once you got that 20 degrees? Can you do the following? Can you abduct your right leg and can you adduct your left? Because if you can't abduct your right leg and adduct the left, you can't maintain a big bone on the left side. You can't get it. That's the question. Can you shift your body weight, Chad, over to which side? The left. That'd be a yes or no. You're in a new position, ma'am. I'll bet you know, Carl, next time I see that lady, what we're going to be going after next. I'll bet you know what that's going to be. But if I gave her the adduction program on the very first day she came in, and she can't spell the word hamstring, am I doing her a favor? No. So we're going to start her on our frontal plane program. That means she should be able to lay on that table on her left side with the towel under her left abdominal wall to preserve left thoracic abduction and adduct that left hip, which is really adduction of an acetabulum on the femur. If she can't pull her acetabulum into that mat and move that acetabulum on top of that femur, did you see how I'm staying it? Versus lift up your leg, internally rotate your leg, keep it straight, and use your adductors to pick your leg up. There's a difference. Can you push your left hip down into that mat while you pick up that leg? Because if she can't push her adductors down into that mat, she might be lifting that leg up with her back on the other side. Now, we're going to go over tomorrow afternoon the Huruska adduction and abduction lift test. And Mike Cantrell did a great job in the back of your manual to supplement that program on how to do it correctly. But you know what, Sheila? Making you understand how to do it correctly versus making you understand why you even need to do it are two different things. First of all, you have to make sure you understand why would you do it. Why are we here? Why would we do that? That's frontal plane, 30 degrees. 40 degrees of IR, 60 degrees of VR. This is a person that's got a little bit of a challenge. She's a PT I used to work with. Got a little bit of a challenge. She has way too much internal rotation on her right side, which means that's the first indicator she probably is a little bit of a pattern called, let's see if it gets you guys with me now. If she's liking to stand on her right leg a lot and her weight shifted over to the right, we call that a left AIC pattern. She's sitting in a position, until proven not guilty, the pelvis on that patient could be forward on which side? Left. Good. Some of us are with us. Could be forward on the left side. Therefore, Bobby, if the pelvis is forward on the left side, the pelvis that I'm testing right now for internal rotation could be which way? Posteriorly rotated. Until proven not guilty, I'm going to take a measurement, I'm going to reposition my patient, I'm going to come back and check to see if those values are the same. If she drops off 20 degrees of internal rotation, is that a good day or a bad day? It's a good day. If I get her in the right position, she drops off 20 degrees, isn't that a good day? I just saved her spine from a doctor. I just gave her more energy when she was labeled with chronic fatigue syndrome. I just took off a hip impingement pattern waiting to come. And I definitely resolved her SI problem. You guys with me? Do you see how big that goniometric measurement? In other words, Medicare, was there a result in your treatment? Did the range of motion go up? What code are you going to give it, a G or H? What percent of this is involved? Because see, you can't answer those questions if you first of all can't tell me the position your patient's in. Because how are you going to promise me that your program is going to work if you didn't check pre-measurement and post-measurement for rotation? This is a young lady who has lots of internal rotation on the right side, limited external rotation on the right side. What do you think is happening here? She's in a left AIC pattern, but her external rotation is limited on the same side. She has lots of internal rotation. Anybody want to take a stab at why the external rotation is limited on the right side? Why would the external rotation be limited on the right side? She's sitting on this mat. Her pelvis is forward on the left side. Her pelvis is posteriorly rotated on the right side. And if I would have taken her leg and moved it over here and checked her, I bet we'd have beautiful scores. But we didn't get that in school, Mike. We said, sit your patient up on their butt, on the edge of a seat, and measure rotation. Now, she's got a femur over here that's brought to the midline. But remember, this acetabulum wants his femur over here. But we didn't get that in school. We said, put it right here. And now she takes her leg and she tries to externally rotate, and she takes that head and pushes it into what? A superior, anterior superior labrum that says, stop, you can't move. But you can sure move a lot in internal rotation, but stop, you can't move. That is an impingement syndrome. Stop, you can't move. Forward, back, would be fine here. She can move either way here, but boom, in school we were told to go which way? Right here. All that internal rotation, no problem, but stop. You can't move. Is that a good day or a bad day for this clinician? It's a great day. I don't see pathology yet. Perfect. You're human. It's a good day for me. That's a good value. Here she has more internal rotation than external rotation as well. Uh-oh. I wonder if this individual is forward on both sides. Do you follow me? I wonder if she's got she could maybe not have a limited pelvis that's going back on the right, but since this is limited in external rotation, she has full internal rotation on the left. But remember, her femur should be which way, everybody? On the left, going towards the right. But a minute, I moved it out again. So that wouldn't be an uncommon finding either. The only way you're going to know what the true value is to make sure she can do what with her pelvis, with her acetabulum. Before I go any further, extend, extend, extend. She needs 20 degrees of extension on that hip on both sides. This is a person who has way too much external rotation and way too much internal rotation. Do I need to do any goniometric measurement on this individual? Her pelvis can extend and flex and rotate and adduct and abduct, and you know, clean leaves out of a gutter. It'll do anything. Do you follow me? That's hypermobility. That's why that picture's there. What would I want? Is this a good day or a bad day? Would I rather have this patient come in or this patient come in? I'd much rather, Katie, have this patient come in. Much rather have this. This is kind of a tough case because there's lots of other things going on with this individual. First of all, genetics. Second of all, she doesn't know how to use tone. She doesn't know how to move with tone. So for her to just stop, Gibby, is like putting somebody in a casket and closing it. She can't stop doing what? Moving. She's happy, probably doesn't have a lot of pain. I'm going to be realistic with my program. I'm going to get you on what kind of a program, Carl?
Hamstring program.
Just to start giving you some idea of how you feel when you weigh yourself. Weigh yourself. 20 pounds, 30 pounds, 50 pounds, what do you think you weigh? Don't get on a scale, weigh yourself. What do you feel today? I want you to weigh more every day, a little bit what? More. Because if she's feeling light, I don't have her hamstrings. I want her to weigh herself every day. I want you to feel that floor. I'll bet I'm going to give her propulsive activities for her quads and hamstrings to co-contract so she can get a better ownership of who? Her body. But that's a much higher challenge than the former slide. What's wrong with this picture? Way too much external rotation. Way too much. Even if she was in a neutral position, I know her capsule on the right side, posterior capsule right side, is overly stretched out. I know she's been on her right leg a long time for a 14-year-old. And I know all this capsule back here has been what? Stretched out. And then I sit her up and she's got all this external rotation. There's no impingement. There's no tension. There's no tensometer down there. There's nothing. Left side looks pretty healthy. She's overworked which side? She's overused which side? She's overstretched which side? She was developing at the same time she was over-lateralized on that side. Now, not only does she need, let's do this closely, a left hamstring. She does. Badly. If you told me she needs a right hamstring, you wouldn't be wrong, but you're way off scale. She needs to get off her right side and onto her left side. What's going to pull her over to the left side? Don't say glute max because she does not have it. A thing called an adductor group, a thing that's going to pull her pube to the left side. She gets her adductors on, and what particular program over there is she going to need lots of in the year 15 and 16 of her life? Katie, glute max. I can see every birthday candle on her cake. It's called the glute max cake. One more year of glute max. You understand that, guys? This young lady has one thing in her life now. She's going to marry a glute max, have kids called glute maxes. She's going to think glute maxes, eat glute maxes, breathe glute maxes, and I think you get the picture, Gibby. She needs what? Glute max. But you can't give her a glute max if she doesn't have her left hamstring and she doesn't have the ability to frontalize over to which side? The left side. Well, we're going to give her that because she's only 14. But that little leg up there on that left side doesn't exist at all on her left side. But we want the muscle on the right side to get huge. Is her glute what? Because someone took a goniometer out and said, ma'am, not only can you not adduct your left leg, adduct your right leg, not extend either leg possibly. Do you follow me? You have a problem. We would call that pathology. And pathology means you got to really work a lot at getting triplanar concomitant activity and then say a little prayer. And she's only 14. So I'm sure we can do it. What's going on with this lady? This lady can do this. This lady can do this. What's wrong with this lady? If you said the same thing, she doesn't have her glute maxes, you'd be correct. Neither one of these young ladies have glute maxes. I'm going to give you a little secret. Anybody below the age of 17 with a pelvis that's not in the right position, I guarantee you they don't own their glute maxes. Remember that picture of that glute max? I said, I love this picture. They don't have glute maxes. Right glute max in these young ladies' lives do not exist. On which side? Would I go after either one of these ladies' glute max on the left side first? Because left glute maxes push you over to the what? Which one would I go after first? Well, you have a whole program in your appendix, Bobby, on right glute max. And if there's one thing I'm hoping by the end of tomorrow you all understand how to do, is co-activate right glute maxes with everything you do in life. Right glute maxes. They're as big as left abs in another course. They're as big as the ischial-condylar adductor. They're big muscles. They're really, really important muscles. It controls the floor. It controls your breathing. It controls flow. Right glute max, you can never, ever, even if you don't know what you're doing, humor me and put them on a right glute max program. Because the right glute max can actually reposition your pelvis. It can actually substitute for the adductor and the hamstring on the opposite side if your body's capable of shifting. You can't go wrong for a treatment program to use a right glute max. You cannot go wrong. You screwed up on the repositioning issue. You screwed up on the frontal plane issue, not intentionally. And you say, I don't know what's going on. Monday morning you start this program, Carl, I don't know what's going on. I don't know what to do. You'll get full credit. Dave will give you full credit if you just go to that right glute max file and pick something out. That's a little secret in the last few weeks you got here. Just pick something out of that right glute max file, you got her made. You cannot screw up. What's wrong with this guy? That's maximum range of motion. Used to be a football player for the University of Nebraska when we were in our losing seasons. No transverse rotation. 5 to 10 degrees. No transverse rotation. Do you see that, Mike? That's all he's got for IR on both sides. Now, what's going on if that's all he has for IR and he has a lat that's strong and more than 30 degrees of lordosis in his low back? What's going on if he's only got 5 degrees of internal rotation? Because he should have 45 degrees of internal rotation right now. What's going on? This guy has overdeveloped his glute max muscles. They're powerful in a pathologic state. He went after glute maxes every day. Powered them up, Pat, without any transition. Powered them up. He got his glute maxes strong, Chad, in what plane? By the way, it's the only plane in his life right now. Sagittal. This is called sagittal football. He can push off that line like no other. But he can't cut. And if the runner runs by him, he's done. But he can go forward. He can push that line like no other. As long as that line is not moving one side or what? The other. So he overdeveloped his glute max muscles and a pelvis that's too anteriorly what? Rotated. Can you imagine Pat telling him, because his doc says he's going to need a new hip on his right side. Can you imagine me telling him, here's what you got to do. Lay low off the weights. Okay. First of all, that ain't going to happen. Lay low off the weights. Okay. Put some roller skates on and start inline skating. Because he doesn't even know what a roller skate would feel like. Because he'd have to use glute med and glute min. Oh my God, I don't know where those are. That's a sin. All I want is he put him on roller skates, and he would never be able to push himself which way? Forward. Never. Bump, 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 bump. He'd never get forward. He'd be a tower. You know what a tower is? Back of the skates, toe, push. Back of the skates, toe, push. Because Pat, he can't externally what? If you do the math, for you to walk in life, you have to externally rotate at push-off. He can't. So the only way he can push off of it is big, huge, nice-looking calves or chins or tibs. You follow me? He's an animal that's totally, totally dependent upon sagittal pull. So he's going to wear his hip out because he can't get off the front and the back of his sagittal plane of hip activity. What's wrong with this lady? Not a lot, but what's wrong with her? Is that healthy? No, because see, this lady here can do that. And normally people want this to do that. You don't need this to do that. Did I lose you? You don't need 130 degrees of this to do a split, because all this lady has is that. She can do a split because she's got one side doing that while the other side is doing extension, and she's doing it just fine. Versus the world that thinks you've got to do that to do this. That is perfection. You're always going to have a little harder time doing it here because our hips work better here. This is more AFIR than this is. She'll tell you that. But she didn't have to do that to do that since she's only here at that. Am I losing you at this? Did I lose you? So when someone says, I need more than 100 degrees of flexion, I would say to you, Chad, why? Because your 14-year-old brain is around people that say you need to get more to do a split. If you want to get more out of a split, Carl, would you help me out as a parent? Would I need to do more of this, Carl? Or would I need to be doing more of a hamstring program?
Hamstring program.
I would hope to God you understand that. Because if you do more of a hip flexor program, now you're creating a back that's going to give you the splits versus a pelvis that should give you the splits because that's fast running. You're not even on the ground. Does that make sense? Let's go, Carl, see how opposite we think? That is not going to give you the ability. That's called hyperextension of a knee. That's an overquadded program. That's a rectus femoris psoas muscle that's working too hard. Does that make sense? And her body then has to adjust to that position through extension of the back. You'll never become an Olympian looking at that. You definitely will become an Olympian looking like that in midair. These are slides of what the left and right leg look. This is the pelvis. This is the left side. So you're looking at it from the back. Look at this obturator. That's a spine that's oriented to the right side. Okay, so look at the anomalous. This obturator is inwardly oriented. Inwardly oriented. This flare is there. You can see the flare. It's wider here than here. And again, look at the obturator. It's more of a, it's not a squinty eye, but it's more of a narrow eye. Look at this little glute med. Look at this right glute max. Still holding them up. More on the right side. Zipper shifted over to the right side. Okay, I got that one. Let's go on to the next one. This is a better picture. This is looking at an anterior view of a different pelvis. I love this one. See that obturator, how closed off it is? Look at the asymmetry of the inlet. This can be a wider nominate, narrower nominate. You can sometimes look at the greater trochanter. This is facing you a little bit more than this one is. There's some other pictures coming up that'll show you that. This femur is being pulled more to the midline than this one. She's being pulled over. So when you take the picture, this is going to be more forward and more internally oriented. Guys, if you have any questions, let me know. Just showing some pics. That's all we're doing. I like this clear one. Anterior view of the anterior forward position left innominate. See a little bit more squinty. A little flared. Not as much asymmetry. Not much more, but other than just a slight amount of innominate orientation forward on the left. Clear view though. This one I know where this one came from. Man, do I like it. This is the best. When I asked to get this, Jet, I think you know, Jen, where this came from. When I asked to get it, I said, get it as clear as you can, because this is really a very, very cool picture. Look at the size of this innominate. Look at the size of that left innominate. There's the obturator. Starting to see a little bit of a pattern here, guys. You're going to see this a lot. This person was not standing. This person's laying down supine. Legs are out. So you can't look at the two femurs. But look at this. Lovely picture. Don't know the history behind this one at all. Okay, this is the left side now. This is the left side, anterior view. This is the right thoracic curve. You're going to see lots of right thoracic curves. Very narrow pelvis. The reason I like this is because very narrow pelvises result in thoracic curvatures. So the more narrow the pelvis, the more narrow the mouth, the more narrow the body, like you've got, the more likelihood of curvatures. So you won't see as much torque on this one, but you're going to see a lot of torque. When you have flares down here, you're not going to have flares up here. It's just something over the years I've noticed. If you got a big flare on the bottom, Katie, you're probably not going to have a scoliotic back. If you got a little flare, no flares, probably somewhere that rotation's occurring. This is a 23-year-old person with a bilateral anteriorly rotated pelvis. This is the left side. This is the right side. Again, see the narrowness? I just threw some narrowness in here. Real narrow, long, elongated pelvises. Bilateral. So the next thing, the more narrow you are, the more likely you're going to become bilateral. So there's a couple rules here. The more narrow you are, the more likely you're going to be a PEC. Just some thoughts, okay? Colleagues in the room that know this, they're shaking their head inside. Yeah, we see it all the time. Now what I did is I took the pelvis and I held it. Actually, I think that is my hand. I'm not sure. This is years ago. I think I did. And I said, Rob, I said, take a picture from the top down. So I put this person into what we call a gap, a right SI gap, right oblique axis, right rotation on right oblique axis. Spine is oriented to the right. This innominate going posterior, this innominate going forward. As it slides forward on that sacrum, it's going to be pushed out on the top. That's a flange, that's a flare. And that's what it looks with the camera on this transverse and spinous processes. You can see orientation to the right side. And I did not move. And I said, Rob, take your filter, your camera, and focus on the knee now. And he did, and I didn't move. I stayed in the same position. And now you can see the orientation of the femur on the left side with the orientation of the femur on the right side. Now, that inward orientation reflecting this innominate would result in that kneecap someday being right here. Now this is back, way back in my 80s, 1980s, where patellofemoral pain was only patellar femoral pain. And that amount of patellofemoral pain on the human body didn't make sense to me. This is a femoral patellar discussion we're having right now. So we discussed this morning. That's why we call it a femoral patellar issue. Then I said, let's get somebody who's had an MRI done. This is a lady back in the early 90s that was a patient of mine and said, man, I love this MRI. After I requested the doctor do it. Could we slice this baby in 3 or 4 sections and get it? And she paid for it. We got it done. And because she's in significant pain. Now this is the right side. So you're looking at it from, do you follow me? You're looking in her, okay, or him, okay? And it doesn't matter, it was a her, but you're looking in it. And you can start to see the right side gap again. So you know the pelvis is forward, Katie, on which side? And the innominate is back on which side? That's a right rotation on right oblique axis again. And we're just gonna keep going. Okay, there we go up a little bit. Start to see more gap. On which side, everybody? The right side. And now we're a little higher, more gap on the right side, because the innominate is forward on that. It's coming forward, so there's gapping going on more as you go up. So you start low, you go up, and you see more gapping. That is not form closure. That's form what? Opening. So the minute you start to go into more lordotic rotation or more anterior rotation, you're not getting good form closure. You're actually opening. You're actually opening it up. And now movement. And why do you open up your SI joints? Because, Drew, you want movement there because you lost it at the hips. So the more I go forward and the more I encapsulate my femur, the more I have to get motion out of my body through my other joints. And one of those joints is called the SI joint, as you all know. I also asked Jen to put this page in. Jen, you can throw the light back up if you want. Iliofemoral, pubifemoral, page 14. Can everybody go to page 14? And on page 14, I like this graph because it's talking about corresponding not just muscle that's ligament or ligament that's muscle, which it does a nice job of, but let's go over here. Circle this column, everybody. Circle this column. The iliofemoral musculature has an impact on F on A. F on A. When I want to move my F on my A, I'll probably use that musculature to do it. One of them happens to be a vastus lateralis. Underline it. All those muscles on that sheet are internal rotators. So if you want to write down IR muscle, that would be great. The pubifemoral ligament musculature, also write down the word IR muscles, are also femur on acetabular corresponding muscles. The reason I like this graph is because the ischiofemoral ligament is ER muscle. Write the word ER muscle. And then underline the word gluteus maximus. And then go over to the corresponding joint. That is an AF component. So your external rotators are AF movers. Gravity is an FA movement. Internal rotation is an FA movement. You need in life to pronate, to go through neutrality using IRs and gravity for FA movement. Then when you go into AFIR, you don't really do it with more of those gravity and internal rotators. You do it more with corresponding opposite AFER, which is what you circled, which is an important thing, and I'm not sure the other speakers do this, but I'm doing it. I'm saying when you say AFIR, that means you moved your acetabulum on your femur, but you realized you needed FAIR to get there. To seal the deal, you better have the AFER muscle helping you get into AFIR on the other side. More FAIR isn't going to give you better AFIR. I'm on tape saying that. Should I repeat that? Jen, should I repeat it? More FAIR is not going to give you better AFIR without corresponding contralateral AFER. Because the only great AF muscle you got, what are you always going to not fail with? Glute max. I better see a glute max program there with that adductor program. The adductor program is going to get me to shift into frontal plane. But to seal the transverse movement of A on F, I better have a, what does that say down there, everybody? What does it say? Glute max. I'm getting a little hyper because I'm not sure, I'm really not sure the PRI Nation understands that. You understand what I'm saying, Chad? If you're going to get somebody up in AFIR and you just dropped off the opposite glute max, I'm a little concerned. I'm a little concerned, Gibby. Because more adduction and more work with IR is not going to give you better AFIR. Because you got to stay over there. You got to control it. So I'm getting a little hyper because I really want you to understand that AF, it's been in the manual for years. AF is glute max, more than frontal plane. Frontal plane is more for, FA. Can you adduct? Can you move your femur towards the midline or your pelvis towards the outside? Using an adductor group and an abductor group that are appendage oriented. Appendage oriented. We have an Haruska adduction lift test and abduction lift test for appendage orientation. Give me a 3. That means you got your appendages. Then give me, beyond that 3, you better have contralateral pushers. Because you're not going to pull up without contralateral pushers. That's my take on it. Everybody has a different take. That's my personal take. That's why the rest adduction and abduction lift score was even given you. We'll go back through it this afternoon. Are there any questions about this sheet? So when I say AF, IR, you know I mean I want Katie, I want the acetabulum to go in femur and internal rotation. And gravity will assist me if I bend my knee. And the adductors will definitely pull me over there. But if I don't have somebody pushing me over there when gravity no longer exists, do you follow me? When I don't have gravity, or when I don't want to rely on my weight for that, or I want to seal the deal as things are moving around to the opposite side by staying there without falling over there, like a mouthpiece or a pair of glasses or a sport that I chose, I better have my contralateral what? Glute max. I hope you guys all got that. Okay? That's why I went over here and I wrote down that triplanar need for transverse activity in this MyoChem program, Katie, has got to come from that lowest fiber on the totem pole. The lowest fiber on the totem pole is your inferior glute max fiber. There's nothing lower on the totem pole. Now you're into the knee. So that lowest fiber is going to give you the lift and the push to seal the deal. So any glute max program we pick in, where you've got that control while you're in the opposite state of AFIR, holy moly, the femur can now roll and move and do things it could never do before because we got hold control, baby. We got glute max, piriformis obturator hold control. After lunch, we come back, and we're going to get the colors out, and we're going to start talking about rotation, okay? Transverse plane. How'd that go this morning? Anybody have any questions? How are we doing, Brian? Anybody who's taken this course more than once? What's different, Carl? Is there anything different? Are you learning anything different?
Oh, yeah.
Give me a couple things that you learned this morning. While he's thinking, does anybody want to pull anything up? Is there anything this morning that hit you, Bobby, for the first course?
No.
First set course?
This is my first course, yeah.
First course? Anybody take it for 2 or 3 times? Is there anything that came up? I'm just curious. What did you learn
I just
today?
think hammering home right glute max.
Hammer home the glute max. Very good. I'm really hammering that.
With
Anything
the
else?
adductor.
With the adductor.
Yeah.
You got to have an adductor. Don't misinterpret that. Yeah.
Just more integration this time of how to get it. One side has to let go to get to the other
Yeah,
side.
you got to let go one side to get over there. More discussion about inhibition a little bit. I love it. Thank you. Chad, you've been in a few of these. Mike, any comments? We'll take that table.
I guess crawling in 90-degree positions.
Big deal. 9 degrees.
Especially the warm up.
Warm up phases. Joe, you do a lot of things in 9 degrees. Warm up crossovers. Really important. Keep that loose. Give them some life with that looseness and before you get them up. You guys are awesome. We'll take about an hour break, okay? And we'll come back and we'll start back up again with rotation. Thank you so much. Good job.